We'll move on to the next talk by Dr. Keerthi Punamiya, the role of dual antiplatelet therapy in second generation DIS.
Anyway, good evening and thanks again for having me on this podium. My task today is to talk about dual antiplatelet agents in the second generation drug-eluting stents. The question posed in front of me is, do we stick to the 12-month guideline of dual antiplatelet agents, or can we reduce this to 3 months of dual antiplatelet and still maintain safety? I guess from the experiences from the first generation DES, case reports of death due to late stent thrombosis with DSF appeared around 2003-2004. This translated into pathological studies from Jones, which talked about DS more than 30 days old had late stent thrombosis with delayed healing and poor endothelialization. And this with our own experiences of angiographic nasty images over the last few years from our first generation stents in terms of coronary aneurysms and proliferative intimal hyperplasia in the stented segments, 6 months and as long as 30 months after a sirolimus-eluting stent. And then the SCAR registry, which actually associated an increased death compared to BMS in this DS group. It's for the first time that people started thinking that DS is actually killing patients. And there was a revision of our 2005 guidelines in that the US FDA advisory panel sat in on the recommendations based on the CIPHER and the TAXUS data. Aspirin was then continued indefinitely, and P2Y12 inhibitor therapy was given for 12 months. This was reinforced by a multidisciplinary science advisory statement at about the same time. But none of this was based on randomized controlled trials. What was driven by? It was driven by observational data. We know the pyramid and the tri relationship between the 3 Ps, the patient, the product, that is a device, and the procedure. And we can't get away from the fact that we had to have a better device and see if these differences would kind of, these nasty experiences from the past would disappear. And yes, when we look at definitive stent thrombosis, which used to be the bug from the first generation stents, we realize that the everolimus-eluting stent did well compared to the paclitaxel-eluting stent and the sirolimus-eluting stent, as it's shown in this slide here, with the last line showing almost like a horizontal curve extending up to 4 years. So the question that comes to our mind, which is a natural fallback of this data, is, are these stents, the second generation stents, ready for an easier dual antiplatelet regimen? And to answer that, I think one of the largest growing evidences is from the Science DAPT data, which takes in approximately 13,000 patients over the last 2 years. And all this projected, and this is the submissions, to see if we could get now a 3-month DAPT indication for Science. And if you look at this data, the ScienceV US data, it's a large US registry with highly complex real-world patients. And the second blue panel shows that it's 5,000 patients taken in, and all that busy slide wants to make, we just want to make a point that all kinds of patients were included in this trial. Out to 1 year, subsequent late stent thrombosis, ARC definitive and probable taken into account, and if you can see, the data was divided into 2 groups, the standard risk group and the all-comers, which is the extended risk group. And you can see that there was a 0% stent thrombosis from dual antiplatelet interruption after 6 months for the extended risk patients, whereas for the standard risk or the low risk patients, after 30 days there was no stent thrombosis out to 1 year. When you look at the meta-analysis presented by Greg Stone at the TCT 2011, 13,000 patients almost from the SPIRIT trials, including the ScienceV USA and the Science India registry we looked at. Here there was something different. What's important to note is the definition of dual antiplatelet agent interruption. And it was either aspirin or thienopyridine not taken for at least 1 day or more for any of the following reasons, which could be dental procedures, orthopedic procedures, endoscopies, cost, and various other issues. And what you find is that that red line signifies the leveling that on the left of the bar, the smaller bar, shows that if you did not interrupt dual antiplatelet agents, which is the far left bar, is similar to if you interrupted dual antiplatelet agents after 90 days, and then the stent thrombosis rate out to 2 years remains the same. The problem arose if the dual antiplatelet agents were interrupted within 90 days of the index procedure. And again, the science shows no signal for an increased risk of stent thrombosis to dual antiplatelet interruptions at 3 months. Spirit and compare, this was presented by Alvin Keerthi at the TCT 2012. It took the 3 Spirit trials and it added the compare trial, and we know the compare trial was a comparison between Zions and Taxus group, the paclitaxel-eluting stent. If you remember and recall the Lancet paper, and its conclusion was that the paclitaxel stent probably should not be used anymore as far as the drug-eluting stent platform is concerned. And what it showed, what Alvin Keerthi showed in this, is that the stent thrombosis, when you look at the ARC definitive and probable stent thrombosis, then important is that permanent dual antiplatelet discontinuation beyond 30 days did not impact the stent thrombosis rates at 2 years in the Zions-treated patients vis-a-vis the Taxus patients which had an increased stent thrombosis. Now, if you look at the 3-month DAPT data, pooled from 10,615 patients from 4 real-world trials, as mentioned above over there. And if you look at the timing of the first DAPT, and if you look at whether timing influenced it, whether before 3 months or after 3 months influenced it, conclusively, Zions 0% stent thrombosis rates after dual antiplatelet interruption from 3 to 12 months. Do these data also kind of pan out for the other second-generation stents that we have, like the Zatolmilast stent for the Biolimus stent from Biometrics, and all the other stents that we're talking about. And from here, when you look at the Certex, the leaders and the Certex trial, you see that you see that most of these second-generation share the same low stent thrombosis rates out to 3 years, sometimes up to 3 years in some of those trials. So, when you look at the data regarding this issue, one of the stent which has some data to talk about is the Zatolmilast stent. If you look at the SENSE trial, which is a non-cardiac surgical procedures which required a brief interruption of dual antiplatelet agents within 12 months of a Zatolmilast stent implantation, it was a prospective multi-center registry involving around 3,000 patients. The outcomes occurred, there was an outcomes which occurred in around 6.3% of patients. And dual antiplatelet agents, like all other situations, were interrupted for dental, orthopedic, or endoscopic procedures. The intention, what is important over here, this was the first time it was an intentional interruption of DAPT. If you recall, in the Zions data, it was not necessarily an intentional interruption of dual antiplatelet agent. It could be something like the patient forgot, or he found it too expensive, so he discontinued it, and things like that. Here we are talking about an intentional interruption of dual antiplatelet agent, and we looked at 30-day perioperative adverse events. There were 4 events, 2 deaths, 2 MIs, which is 2.1% occurrence. And 3 of these events happened when the surgery was performed within 3 months of the stent implantation. When you look at the DATE registry, which is a 3-month DAPT after implantation of the Zatolmilast stent, again, it's a prospective multi-center registry with 800 patients. It excluded the high-risk patients, and here we are looking at low-risk patients. We excluded cardiogenic shock, stent thrombosis, ST elevation, myocardial infarction, previous LV dysfunction, bifurcations, left mains, grafts, all those things. Looked at a composite of death MI at 1 year. Then you look at this, and what you see is that discontinuing any of the thienopyridines at 3 months after a Zatolmilast stent implant in a low-risk group seemed safe up to 1 year with respect to stent thrombosis and the composite endpoint. I like to include the RESET trial, which is as far as my knowledge is concerned, as far as the reading is, everything that I researched looks like that this is the first absolute randomized, prospective, open-label randomized trial. None of these other trials are randomized trials. Most of them are observational data. This studied the real efficacy and safety of a 3-month DAPT for the Zatolmilast stent. And the trial design was a little complex with arms which included and evaluated the diabetes group, the acute coronary syndrome group, short lengths of stents and long lengths of stents. It also compared the Zatolmilast and the Resolute platforms. And what it found is that the Endeavor Resolute platform with a 3-month DAPT was non-inferior to standard therapy for primary endpoint of MACE, and stent thrombosis in the two groups were similar. So why do we still need to have dual antiplatelet therapy? I mean, can this data be enough to cut short our dual antiplatelet therapy? We cannot forget where we came from. We first started, when you remember the trials of CURE and EpiCure and all those, you look at the Duke cardiovascular database and the Charisma trial. If you look at the Duke database, in patients treated with DES and a 2-year DAPT duration, they experienced a significantly lower rate of death and MI compared to DS and BMS patients who received a shorter duration of DAPT, telling us that the dual antiplatelet agents, when they're given for an extended period of time, do something beyond just the stented group of patients or the stented lesions. They probably act on the coronary artery tree on a whole and reducing ischemic problems. If you look at the Charisma trial, a significant reduction in the late ischemic events with long-term aspirin and clopidogrel compared with aspirin and placebo for patients with established vascular disease. This benefit was not extended to people who did not have a prior stroke, prior MI, or symptomatic peripheral arterial disease. But did this come at a price? This came with a price. And if you look at the short-term data, the short-term studies which are highlighted below, and compare them to the long-term studies on dual antiplatelet agents, from 8 randomized trials, 91,000 patients. This is a lot of patients we're talking about. But the group that is above is approximately 20,000 patients. You see that this came at a price of bleeding. So it's good to have long-term antiplatelet agents, but it comes with a bleeding complication. Nakul Sinha and all of them have actually very eloquently elaborated all this in the previous talks. So, we saw recently the CIFU Section 8, which kind of represented the trial statement for the European Union, and the Science, and what it said ad verbatim was, Science demonstrated a low stent thrombosis rate in those who either discontinued or interrupted dual antiplatelet therapy after 3 months post-stent implantation. It is therefore recommended that patients treated with Science stents on DAPT for less than 3 months, that it is therefore recommended that patients treated with Science remain on DAPT for at least 3 months. This statement is no way saying that they are now recommending just 3 months of dual antiplatelet therapy. This is basically opening up an avenue for interventional cardiologists to be able to put in a drug-eluting stents in patients who may require an interruption soon, but give them still the benefit of the TLR benefits of drug-eluting stents. Do I have reservations to this data? I do. The trials which examine relationships between dual antiplatelet discontinuation, which is a huge phenomenon, and you see it in trials, and almost 15% of populations stop or interrupt their dual antiplatelet, so it's a very frequent phenomenon. And then you start associating it in terms of relationship by causative or any other with an independent observation like stent thrombosis, which is a very infrequent occurrence, then that, in my opinion, is a statistical miscalculation or misinterpretation. Most of this data that we talked about is observational, non-randomized. At best, all it can do is generate a hypothesis, and this hypothesis will have to be tested into a randomized controlled trial. Definite stent thrombosis is infrequent, rare, and by itself is not enough to change outcomes. And we haven't seen much data which says that because of an increased stent thrombosis, death, MI, and cardiovascular long-term outcomes have changed. And we need to wait probably for that kind of data to be able to make major changes in guidelines. The study have maximum follow-up of approximately 2 years in the ones that I've talked about. What happens at 4 years? It was at 4 years that Winnaker actually announced the death from the DES. I think we need to wait a little longer before we can get there. So what do I conclude with? Summary, my thoughts, is 3-month DAPT or less safe? Yes, it's safe probably. It's safe. But can we recommend it? No, the ACCHA still advises 12 months for the DES. EU may have moved to 3 months for the everolimus stent, but that is an opening to allow people. It is an allowance. It is a stretch of allowance. No randomized controlled trial is definitive on 3-month DAPT. And based on observational data, what can I say? I say that in people who have probably a higher risk of bleeding and may need to interrupt for some surgery, I think yet desire a drug-eluting stent for its anti-restenotic effects or reduced TLR effects. The second generation stents, I believe the everolimus eluting and the zatolizumab eluting stents may be DSs of choice at this present time. Thank you.
Thank you, Dr. Keerthi, for your nice lecture. It opens a new area, where we all have been using second generation DS, but we are continuing to give antiplatelet drugs for maybe 2 years, 3 years, maybe more. But then do we really need to give it? I think the evidence suggests that not more than 3 months probably is not beneficial, rather its side effects will be more. Thank you, Dr. Keerthi, for an excellent lecture, and then I think...
My question to all of us is, the guidelines say that dual antiplatelet should be at least for 12 months, but the practical experience, or I don't have that much of experience, but looking at the clinical scenario in our country, most of us, they are giving antiplatelet combination at lower doses for a drug-eluting stent for a longer period, almost indefinitely probably. What is the expert opinion about it?
Well, I think that the usage of clopidogrel in India with aspirin over a long period is basically possibly because clopidogrel is cheaper than Plavix, which is available and not reimbursable after the next period of time in Europe or US. The benefit of adding clopidogrel over aspirin after 1 year is certainly suspect, and most trials, randomized trials, have shown no clear benefit on combining these two drugs after 1 year. The only issue is between 3 months and 1 year, at least in ACS patients, we know clearly with cure and PCI cure, you have to give it for 1 year. In chronic stable subsets, should we really go beyond 3 months? As Keerthi said, we need some more data from randomized trials, possibly one group pulling off and one group not, with a long 5-year follow-up and see what events happen to really say whether the long-term dual antiplatelet is really required or not, even in the higher risk subgroups of patients.
Hi, Ajit. Ajit?
Yep.
I think this use of dual antiplatelet drugs beyond 1 year in second generation DS is all because we all have some bad experience with first generation DS with late thrombosis. But there is no, of course, when you have second generation DS, somehow people play safe. That's the reason, even though there is no evidence to go beyond 1 year. I think a time has come where we can stop it after 1 year and then probably see.
We went through this whole thing in 2003, 2005. 2005 guidelines said 3 months of dual antiplatelet agents and then you could continue aspirin. What happened to us? It came back and bit us in 2005. We changed our guidelines in 2007. 2007, we had a new guidelines which stated 12 months. This was not based on any randomized controlled trial. It was arbitrary, and this was for the first generation stents. And the second generation stents have just got a hand-me-down order, which was based on the first generation stents. But today in our society, we have a mix of first and second generation stents being used. So as a guideline, I think we still need to have that 12-month guideline. But in terms of individual practices, can you make an allowance in a particular case which is low risk and say, okay, you know, if this patient is going to need it for 3 months and I may need to take out his prostate or I may need to do something as, you know, high bleeding risk for that, then yes, then you may say instead of putting a bare metal stent and giving him a TLR, the guidelines allow you comfortably without getting sued that you can use a drug-eluting stent with an everolimus platform or a zacrolimus platform, and you'd still say that this is within the purview of the guidelines. That's all. But you can't make a statement saying that now we can stop it at 3 months. We don't have that data.
Yeah, continuing on the evidence-based or guideline-based, guidelines are so-called evidence on the literature has significant limitation. And guidelines are not based upon evidence all the time. It is still an opinion. So as a clinician, you still have the total responsibility of what you do to patients from what is available. Suppose you are an angioplaster or a clinician, you knew when you implanted a stent that not everything was that great. There was some haziness. There was some outflow not that great. And there is a residual disease somewhere else. And stent opposition, you are not that sure. You didn't use an IVUS. So in other words, these are all the things that make you deal with individual patients by your own judgment. Guidelines will not take away what you have to do to individual patients based upon your knowledge, experience, and patient factors. So don't ever think that guidelines are going to make things simple for you.
I think, sir, we need more data. There is no doubt, as Keerthi has said, that there are only small trials. Now, one big database will be that ISAR SAFE trial, which is being done by Dr. Kastarati. And that has more than, I believe, nearly 10,000 patients. And it's more than a 1 or 2 year follow-up. It's still ongoing, so we'll need to wait. But there they are testing the efficacy and safety of dual antiplatelet therapy at stopping at 6 months versus at 1 year. But yes, we need more data.
Did you read the science we studied? Like Srihari Naidu's paper in Circulation, it talked about 8,000 patients. It took the same data from the Science V US study of 5,000 patients. And to that, they took together, there's a DAPT trial going on right now, enrollment is on. They took the 2,500 patients from that and combined them and analyzed them. What did it find? They put in a bunch of 36 variables, and they found out with those 36 variables, do they influence TLR and do they influence stent thrombosis and other few other things. And what they found is that the dual antiplatelet stop at 30 days was probably the most powerful predictor of stent thrombosis. But do you know that one of the variables studied in that trial or looked in that trial or in that study was current smoking? So, and what it says was that if you are a current smoker, if you have to follow that observation correctly, then if you were a current smoker, it actually reduces your TLR. I mean, how many of you in the hall actually believe that if you were to continue to smoke, your restenosis would be lower? I mean, can you show me a show of hands? So if you can't believe what happened in that one variable, how can you believe what happened to the other variables? So this is like you throwing into a little pot lots of chits and then picking out one chit and saying, oh, this is what actually this trial shows. It doesn't work that way. All that is just hypothesis. And we need to have a proper study to answer this question.
Dr. Punamiya, Keerthi, one more question. You know, a lot of interventional cardiologists use a double dose of clopidogrel for first 3 months after angioplasty and stenting. Then they go back to, say, like clopidogrel 75 milligram twice daily for first 3 months, then subsequently once a day. Is there enough evidence for that?
I think that's another great question. I think Ajit, I think you alluded to that, and that
yeah,
the
I think there's data from the OSS that if you
OSS 7 came from
OSS 7 that you take 75 milligram twice a day in PCI patients for 1 week after the procedure, and then
1 week it is there.
Yeah.
So
1 week, but 3 months there is no data. So I think
PC, it's only for 1 week. So Dr. Rath, if it was
yes,
for
I know it is for 1 week. OSS 7 data 1 week, but I think lot of interventional cardiologists in India practice giving do clopidogrel twice, 75 milligram twice daily. Some people for 1 month, some people for 3 months. There is a lot of variability in that.
One other thing I wanted to say is that with the newer antiplatelets, clearly the aspirin dosing is coming down. If you look at the ticagrelol data, the aspirin is now less than 100. So, you cannot, if you use ticagrelol, it's better to use lower dose of aspirin and not higher dose, because if you use higher dose, you will bleed more. So I think that clearly using stronger antiplatelets, you have to be careful when you combine drugs and dosing.
We look at stent thrombosis, Ajit.
But that's not the only thing you should watch, because you can get a big GI bleed or an intracranial bleed, which may be as disastrous.
When you start associating something like discontinuation of a medication, which is quite frequent, and say 20% in a trial, and if you're looking at 10,000 patients, 20% is 2,000 patients. So 2,000 patients are going to stop some medication at some stage. You take this variable, and then you take stent thrombosis as a variable, which is around 0.1% or 0.2%. So here we are talking about a very frequent variable. You're talking about an infrequent variable. And now in this trial, we are trying to marry these two variables, saying that this is causing this other variable. That is completely hogwash. That is not how statistics works. That is how we confuse the audience. No trial can do this. All the trials that have gone into this data, the primary endpoint was entirely different. It was completely different. They've taken some of these secondary endpoints and then tried to make a statistical meaning out of it. But I think it's just hypothesis, that's all.
Okay, so we had a good discussion on various areas of newer antiplatelet therapy and the use of dual antiplatelet, and I think we will close the symposium for the evening. I thank Dr. Somaraju for co-anchoring this session with Rath, Seshagiri Rao, Dr. Srinivas Rao and Keerthi. Thank you very much, and please join us for dinner.